Sir.
So the anesthetic management of intestinal obstruction. So it can be classified into dynamic when peristalsis is working against a mechanical obstruction, or adynamic where there is no peristalsis like a paralytic ileus. So dynamic ileus is caused by adhesions. This is a very common condition. Patients who have undergone repeated laparotomies, or ladies who have undergone cesarean section 2-3 times, they're all potential candidates for adhesions later on, or malignant tumors or obstructed hernia, bowel perforation. All these things are causes of dynamic ileus. And the classification can be made depending on the site also: upper small bowel, lower small bowel, or large bowel. And the duration can be acute, chronic, and subacute. So these are the three classifications you have to remember. And whether there is a mesenteric flow compromise or not, that is strangulation. The intestinal obstruction is present mainly with abdominal distension, and in small bowel obstruction, the abdominal distension exerts pressure on the diaphragm, limiting its downward movement, resulting in inadequate ventilation and increased work of breathing. So patients, when they arrive with the distension, they will always be tachypneic. There is a decrease in tidal volume and FRC, which causes a reduction in oxygenation first, and then later on causes a increase in carbon dioxide, producing what is called the type 2 respiratory failure. And upper small bowel obstruction leads to hydrogen, chloride, and potassium loss, leading to hypovolemic, hypochloremic, and hypokalemic metabolic alkalosis. Whereas a distal small bowel obstruction causes more of bicarbonate loss, as the intestinal juice contains more bicarbonate than chloride. The inflamed bowel can also lead to loss of protein. This is another important point which I have forgotten to mention. So hence acidosis and hypoalbuminemia and its consequent fluid shifts can complicate the management. So these are all the things that you have to remember with that. And in large bowel obstruction, accumulation of methane may result in hyperammonemia and alkalosis. So there are various patterns which happen according to the level of obstruction. So the acid-base changes may end up in acidosis if septic shock ensues. So if the ABG shows a shock, acidosis, then you have to think of septic shock also. In large bowel obstruction, except volvulus, the fluid shifts are slow and insidious, and constipation is the most common presentation, contrary to small bowel obstruction, which presents with vomiting more commonly. And the pathophysiology, these are all the universal findings: sequestration of fluid and gas proximal to the obstruction, fluid leaks into the peritoneum also, irritation of peritoneum producing peritonitis, vascular shifts into peritoneal cavity, hypovolemia, and shock and dehydration. These are all the universal things, changes that happen. When it comes to small bowel, there is increased intra-abdominal pressure, pressure on the diaphragm, atelectasis, and pneumonia. Whereas reverse peristalsis will happen, which will result in nausea, vomiting, anorexia, poor nutrient intake, malnutrition, dehydration, hypochloremic, alkalosis. But when the obstruction at the large bowel, gas accumulation, ammonia increases, alkalosis happens. Abdominal distension is a very late sign. Bowel perforation can happen sometimes, and bowel contents leak into the peritoneum. This can also lead to peritonitis, sepsis, and septic shock. And large bowel septic shock is much more dangerous because as the food goes down, it becomes a fecal matter. So the contamination and sepsis and the irritation will be much more. And the four cardinal features of obstructions are pain, vomiting, distension, and constipation. These are the important findings in an obstruction. So you come to the pre-anesthetic evaluation. The most important thing is to correct the fluid electrolyte imbalance and acid base, hemodynamic stability, measurement of abdominal distension and extent of respiratory compromise, and assessment of comorbid conditions. These are the four headings we have to take into that. And what are the investigations you want to do? Routine blood and urine investigations, including liver and renal functions. Serial hematocrit. This is a very important investigation which will help to identify the degree of dehydration. So initially, before you start your rehydration or fluid therapy, this hematocrit will be very, very high. It may be 55, 60, 65 also, because the fluid is lost. But once you start correcting the dehydration, it will come back to normal. So it is a very simple, easy method to assess your success of the hydration by measuring what is the serial hematocrit and hemoglobin. Arterial blood gas analysis, ECG, especially with the long-standing diabetes and hypertension, both you can find out any pre-existing heart ailment by taking an ECG, or any acute electrolyte abnormalities producing arrhythmias also can be diagnosed by ECG. So the purpose of taking ECG is twofold. One is to find any acute changes because of electrolyte disturbance, or chronic changes because of diabetes and hypertension. And X-ray test here will help to find out whether there is any basal atelectasis or pneumonia, especially when the patient comes with a obstruction of 4 days, 1 week duration. And the USG, CT, MRI to identify the exact cause of the obstructions. So these are all the investigations that you do. And pre-op optimization, think of early surgical intervention. It gives a better result than waiting too long. And correction of electrolyte imbalance and acid base at the earliest without wasting time, because we have to take up these cases for a better result as quickly as possible. And relieving intra-abdominal pressure by gastric and bowel decompression by NG tube, that is nasogastric or Levin or Salem sump or Miller-Abbott tube. So this is the common Levin or Salem sump tube which are used for gastrointestinal suction. The Salem sump tube is a little longer than your normal NG tube, and this Miller-Abbott tube, you can see how long it is. It is coiling so much. It can go up to the small bowel, and it has got one for allowing the air to go in, so that the vessel, the lumen of the bowel does not collapse. So the same principle is used nowadays in some other equipment also. Which one? One tube to allow the air to go in, another one for suction. Dr. Ammo?
Colonoscopy.
Colonoscopy. One instrument which you are using as an anesthesiologist. You don't use colonoscopy regularly, no?
LMA.
Eh?
LMA.
LMA, yeah. Second generation and third generation LMAs, all of them have one port for air entry and another for suction. Okay, so this is the reason for that. Unless you have one open to the atmosphere, what will happen if you have only a suction port? The vessel, the lumen of the either your pharyngeal wall or the intestinal lumen, the wall will collapse and it will not allow any more suction to come out. So that is where, and a similar thing. Have you heard of rep global tube? Where is it used? Rep global. Tracheoesophageal fistula. To remove the suction the blind pouch in the tracheoesophageal fistula, they use the global tube, which is designed by a surgeon. He only said there should be a port for the air to enter when you suck, so that the walls don't collapse. So this is the Miller-Abbott tube, which can be used for removing so full correction of dehydration is impossible, as it will only sequestrate into the bowel and increase the distension. So better to go for thoracic epidural with low concentration of LA may help in alleviating the pain without worsening the hemodynamic stability. But the caveat that you have to remember is there should not be any coagulation abnormality, or patient should not be too hypotensive or too dehydrated. So before that, you can correcting all that, you can do this particularly to relieve the problem. So how much of fluid will be lost? At the early stages, it will be 1500 ml accumulated in the bowel. At about little later stages, you can lose up to 3000 ml, and in the very late stages, you can use 6000. That is 6 liters of fluid may be lost, which is accumulated in the bowel only. So it is a very, very subtle, hidden or occult loss. The patient is not losing anything overtly. So this much of fluid can collect in the bowel, and that is why the patient becomes severely dehydrated, and the volume that you try to infuse into the patient, again it may come back into the intestine. That is the reason why you quickly correct to maintain some hemodynamic stability and take up the patient as quickly as possible for surgery. Now, the electrolyte balances are hyponatremia, hypochloremia, hypokalemia, if it is in the stomach. Once you go for the loss of bowel, lower small bowel fluids, you land up with loss of bicarbonate and acidosis. So, metabolic acidosis is more common due to dehydration, loss of alkaline intestinal secretion, and starvation ketosis. So even though alkalosis occurs initially, ultimately it will end up only with acidosis. Intra-op management, GA with a regional technique, either a thoracic epidural or a bilateral quadratus lumborum or a bilateral tab block. Avoid sedative and opioid premedication because the patient may be compromised in respiratory function because of the splinting of diaphragm. Suction the NG tube, intestinal tube before induction and remove it during intubation or induction of anesthesia. This is a very important point. You should not leave the NG tube or the NJ tube in situ because that will keep the, why should you remove it? What is the reason? This will affect the closure of the cricopharyngeus. Okay, cricopharyngeus is a volitional sphincter, the upper sphincter, at the entry of the starting point of the esophagus. So, if you keep the NG tube or NJ tube in situ, it will not allow the cricopharyngeal muscle to contract. And after induction of anesthesia and relaxation, this is a skeletal voluntary muscle, so this will also get relaxed. So they will facilitate more of regurgitation. So you must always remove the NG tube or NJ tube in any patient when you induce anesthesia, not only in intestinal obstruction. And plan with RSI, it can be used tipentone, ketamine, etomidate or ketofol, Saxa and rocuronium, and position 20-degree head down tilt, supine, or other option is lateral position also. So you can keep the patient in lateral, do pre-oxygenation, do induction, and if you are experienced person, you can even intubate in the lateral position itself. Air and oxygen, avoiding nitrous oxide, which was mentioned by Nikhil that it can worsen the distension. The administration of high oxygen during the surgery is important to prevent surgical wound infection. And more doses of muscle relaxants may be needed during surgery and at closure. And this may result in inadequate reversal, especially if electrolyte or acid-base imbalance persists, and result in recuriorization if you try to reverse it without correcting these defects. And hypothermia also will add up to this problem, and recuriorization is very, very common if the patient is hypothermic. And that will use of neostigmine is also a controversial issue, as I told earlier. Coming to monitoring, apart from routine monitoring of pulse oximetry, non-invasive blood pressure, ECG, ETCO2, urine output, monitor and maintain temperature and blood loss. And the hemodynamically unstable patient, go for invasive lines like arterial line, central line, and blood and IV fluid should be warm to avoid preoperative hypothermia. Now, postoperative care of this patient, some patients may require elective postoperative ventilation, which will be decided on the individual based surgery based on the type of preoperative hemodynamic status, intraoperative behavior of the patient, and the extent of surgical trauma. These three factors will decide whether you can extubate the patient on the table or you have to do elective ventilation. And use of appropriate antibiotics, thromboembolic prophylaxis, commencement of early enteral nutrition depending upon the return of bowel function and how abdominal distension decreases. Now, continued postoperative pain relief using low concentration local anesthetic or fentanyl epidural administration will help to prevent atelectasis and pneumonia by the patient ability to take deep breath and even do incentive spirometry and all those exercises. Avoid use of NSAIDs because patient may be dehydrated, and if there is a compromise on the urine output by using NSAID, you can precipitate a acute kidney injury. So preferably not to use these drugs. Watch out for development of sepsis in cases where gangrenous bowel has been resected and anastomosis done. And so that ends the presentation on. Okay. What happened? That is slow.